This is Professor Nicholson lecturing on Complications of Pregnancy, Part 1. Please review Unit 5, Module 1, Subcompetencies. Please note that some subcompetencies will be in Part 2. Society views pregnancy as a natural process with a positive outcome, the birth of a healthy newborn. However, 1 in 4 pregnant women is considered to be high risk or diagnosed with a complication. A high-risk pregnancy is defined as one in which a condition exists that jeopardizes the health of the mother, her fetus, or even both. These conditions may be a result from the pregnancy or could be a condition that existed prior to the woman becoming pregnant. An ectopic pregnancy is defined as any pregnancy in which the fertilized ovum implants outside of the uterine cavity. Common locations include the fallopian tubes, which is the most common, the cervix, the ovaries, and abdominal cavity. The implanted embryo grows and draws its blood supply from the site in which it implants. As the embryo grows, the risk for organ rupture increases as the uterus is the only organ designed to expand with this development. Ectopic pregnancy can lead to massive hemorrhage, infertility, or even death. Ectopic pregnancies often occur from conditions that obstruct or slow the passage of the fertilized ovum through the fallopian tube to the uterus, such as what I have listed here. So you should know that if a patient has had a previous tubal ligation and has a positive pregnancy test, there is a very likely chance it's an ectopic pregnancy. The biggest takeaway is that signs and symptoms typically begin at the 7th or 8th week of gestation, so earlier in the pregnancy. Associated risk factors, missed period and a positive pregnancy test, decreased human gonadotropic levels before 10 weeks of gestation, abdominal tenderness, which could be unilateral, bilateral, or diffused, as well as vaginal bleeding or spotting are signs and symptoms that occur during this time. Signs and symptoms that follow the rupture of a hemorrhage include severe, sharp pain in the lower abdomen, dizziness and fainting, referred shoulder pain. So referred shoulder pain is one of the biggest symptoms of rupture. Hypotension, abdominal distension, as well as hypovolemic shock are signs and symptoms. Diagnosis is confirmed through a positive serum beta HCG level and an ultrasound. Treatment includes medically methotrexate IV, we want to make sure we start treating the patient prior to rupture, and we want to keep the patient stable. During surgical treatment, we would want to do this prior to or following the rupture. Following rupture may involve removal of the fallopian tube. Nursing management for an ectopic pregnancy includes assessment and monitoring. So like I mentioned, that referred shoulder pain, that's one of the tall tale symptoms of a rupture. Vital signs, pain management, emotional support, because this is a loss, as well as education to the patient on what is happening. Gestation trophoblastic disease, also known as GTD. I highly recommend not looking up pictures of this unless you feel like your stomach is at ease. This is considered a tumor developing from gestational tissue versus maternal tissues. It's a disorder involving placental development called a hydatiform mole and neoplasms, excessive growth of tissue of the trophoblast, which is a layer of tissue that later forms a major part of the placenta. So a lot of definitions right there. GTD produces that HCG hormone, so that's human gonadotropic hormone. Gestational tissue is present, but the pregnancy is not viable. you need to know that this is not a viable pregnancy. Notice how the uterus is enlarged in this picture because of the tumor. You need to know that one of the symptoms is that the uterus enlarges at a quicker rate than what you would typically notice. There's a complete hydatiform mole and a partial. A complete develops from a sperm fertilizing an empty egg. There's no fetal tissue developed and no circulation is established. The embryo is not viable. This is associated with the development of choriocarcinoma. And there's also vaginal bleeding that is very dark. The patient can become anemic. As I mentioned in the previous slide, excessively enlarged uterus, preeclampsia, as well as hyperemesis could occur. A partial develops from 2 sperm that have fertilized an egg and provided double contribution. An embryo is partially developed or not at all and not viable. This can cause vaginal bleeding, small or normal-sized uterus based on the gestation, and it can be similar to an incomplete abortion. The biggest takeaway from a hydatiform mole is that there is no hope for the pregnancy because it's not viable. Complete molar pregnancies are associated with the possibility of developing choriocarcinoma, which is a malignancy of trophoblastic tissue. It's important to follow closely for 12 months following molar pregnancy for early detection. There's a risk for metastasis to other organs, especially the lungs. This is highly responsive to chemotherapy with a remission rate that is greater than 90%. You should know that a great long-term goal for a patient is to be cancer-free 1 year following the diagnosis of this. You should be familiar with the signs and symptoms of GTD. Treatment includes an immediate evacuation of uterine contents, a biopsy of tissue to analyze for choriocarcinoma, a follow-up to detect any remaining trophoblastic tissue. So this includes HCG levels for 1 year, a CXR, as well as a pelvic ultrasound. Strong recommendation to prevent pregnancy for 1 whole year. You need to educate the patient to keep all follow-up appointments, especially because you really want to monitor for those HCG levels. Hyperemesis gravidarum, also known as excessive uncontrollable vomiting for a pregnant person. This begins before 9 weeks gestation. It's caused by dehydration, electrolyte imbalance, and weight loss of more than 5% of pre-pregnancy body weight. It typically peaks at 12 weeks gestation and resolves by 20 weeks. Some patients even have it a little further out, unfortunately. Risk factors include hyperemesis with a previous pregnancy, a molar pregnancy, such as what we just discussed, history of H. pylori, psychiatric diagnosis, and one of the biggest ones is a multiple gestation pregnancy. So if there's twins or triplets in there, this really increases your chance of hyperemesis gravidarum. Treatment for hyperemesis gravidarum includes first line being management at home and providing dietary and lifestyle changes, so educating the patient on staying hydrated and having a balanced diet. Second line would be an actual admission to the hospital. The nurse would want to closely monitor the patient's eyes and nose, monitor lab values for signs of dehydration, electrolyte imbalances, and malnutrition, ensure the patient stays NPO for 24 hours with fluid replacement therapy, with slow introduction to bland diet, and antiemetics are usually ordered IV, so typically this would be Zofran. Third line would be continued hospitalization, as well as parenteral nutrition, antiemetics, and additional medications. You should know that continuous fetal monitoring is not a priority for someone who is only in their first trimester. Electronic fetal monitor cannot typically be performed until later in the pregnancy. Yes, sometimes the nurses have an order to check for Doppel tones, but continuous monitoring is not a priority for a first trimester. Checkpoint. When caring for a patient in her first trimester with hyperemesis gravidarum, what is the nurse's priority assessments? Like I just mentioned in the previous slide, the nurse is to monitor for I's and O's, as well as serum electrolyte levels through lab draws. ABO incompatibility occurs only in blood type O mothers whose fetus has a blood type A, B, or AB. The mother possesses anti-A and anti-B antibodies, which can cause hemolysis in the newborn. Thankfully, this occurs at a lower incidence rate due to only a small portions of antibodies crossing the placenta and fetal red blood cells having less surface expression of A or B antigens. Now we're going to talk about Rh incompatibility. This occurs when a mother who is Rh negative is exposed to Rh positive cells from the fetus, which causes the development of Rh antibodies. This development is called sensitization and can cause hemolysis and anemia in the newborn. This process can take up to a month for the maternal circulation to reach fetal circulation and often occurs during childbirth. Because of this, firstborn newborns are not affected, but subsequent pregnancies increase that risk. You need to know that the newborn complication for Rh sensitization is fetal heart failure. Blood incompatibility treatment. So what is RhoGAM? RhoGAM is an intramuscular injection that kills fetal cells that have entered maternal circulation. This prevents sensitization from occurring. Mothers with a negative blood type receive RhoGAM between 28 and 32 weeks gestation. They receive it again within 72 hours following birth if the newborn's blood type is positive. If the newborn's blood type is negative, they do not need to receive it. RhoGAM is also recommended for the following: amniocentesis, ectopic pregnancy, maternal trauma, missed therapeutic, spontaneous abortions, as well as fetal surgery. So, if a patient has a missed abortion and has a negative blood type, you still want to ensure this patient gets RhoGAM within 72 hours. Please note, you do not need to worry about direct versus indirect Coombs for this course. Checkpoint. Which patients should be closely monitored for Rh incompatibility during pregnancy? This is a select all that apply. The answer to this one is A, type A negative, and C, type B negative. Why? Remember, Rh incompatibility occurs when a mother who is Rh negative is exposed to Rh positive fetal cells. This causes the development of Rh antibodies. This is called sensitization and can cause hemolysis and anemia in the newborn. The process can take up to a month for the maternal circulation and often occurs during childbirth when blood is most likely to mix. Firstborn newborns are not affected, however, future pregnancies are. I want you to know the difference between the different hypertensive disorders during pregnancy. I also want you to understand that preeclampsia can happen in the postpartum period too. You should know the signs and symptoms, which we will discuss shortly. And you should know to ask for these signs and symptoms if a patient develops an elevated blood pressure. So chronic hypertension is hypertension that exists prior to pregnancy or develops before 20 weeks gestation with blood pressure readings greater than 140/90. Gestational hypertension is a new onset blood pressure elevation. This is identified after 20 weeks gestation without proteinuria, so no protein in the urine, and it returns to baseline by 12 weeks postpartum. Preeclampsia/eclampsia and HELP, which we will go more in depth with shortly. These are blood pressure elevations identified after 20 weeks gestation with proteinuria and one of the following: elevated creatinine, liver involvement, abdominal pain, so right upper quadrant pain typically, neurologic complications, so headaches and visual changes. Know that eclampsia occurs when seizure activity develops. So it happens after preeclampsia. Chronic hypertension with superimposed preeclampsia. This is blood pressure elevation identified after 20 weeks gestation, and it has an increased maternal and fetal morbidity rates. The following are risk factors for hypertension disorders. Also understand lab and diagnostic testing. So there's frequent blood pressure checks. Patients get CBCs, electrolytes, BUN and creatinine and liver enzyme draws, and also urine specimens to check for protein. Chronic hypertension. Mild/moderate ranges from 140/90 and beyond. Severe, the systolic would be over 160 and the diastolic would be over 110. Chronic hypertension occurs in 25% of women of childbearing age, and its prevalence varies according to age, race, and body mass index. Expectant mothers with chronic hypertension are closely monitored for worsening hypertension or the development of preeclampsia. Women with severe chronic hypertension will start pharmacological treatment during pregnancy. That being said, just a little review. If a patient is on a blood pressure medication, newborns actually typically need to have their blood sugars tested during the postpartum period because it can actually fluctuate their blood sugars. Not something I'm going to test you on, but just some interesting facts. Gestational hypertension is a temporary diagnosis for hypertensive expectant mothers who do not meet the criteria for chronic hypertension or preeclampsia. So diagnosis occurs if the blood pressure is 140/90 on 2 occasions that are 4 to 6 hours apart after the 20th week of gestation. It usually resolves by 12 weeks postpartum. Preeclampsia is one of the leading causes of death and severe maternal morbidity worldwide. It's described as new onset hypertension along with proteinuria and/or maternal organ dysfunction that impacts the cardiovascular, hepatic, renal, and central nervous systems. Preeclampsia is a two-part event. Vasospasms cause elevated blood pressure, which reduces blood flow to the brain, liver, kidneys, placenta, and lungs. The expectant mother then responds to this and experiences symptoms of proteinuria, headache, nausea, blurred vision, and hyperreflexia. This is preeclampsia with severe features. So again, make sure you monitor your patient for signs of preeclampsia, especially if they have an elevated blood pressure. Ask them, do you have a headache, blurry vision, any nausea? Do you have right upper quadrant pain? I also just want to add, it's not really fully understood exactly why preeclampsia happens, but there's research and they believe it has something to do the way the vessels from the placenta attach to the uterine wall. Not set facts, but just things I always research and touch up on. Preeclampsia without severe features. These are patients who are experiencing an increase in blood pressure, but not exhibiting signs of renal or hepatic dysfunction. Management includes bed rest, increased frequency of diagnostic testing and prenatal visits, blood pressure readings every 4 to 6 hours, closely monitoring fetal movements, a balanced diet with good water intake, and non-stress tests and ultrasounds to monitor for fetal growth. Again, NSTs are frequently ordered for patients diagnosed with preeclampsia, so their OB visits are much more frequent than a patient who has a less risky pregnancy. Preeclampsia with severe features. Patients who are experiencing an increase in blood pressure and exhibiting signs of renal or hepatic dysfunction and symptoms of such as epigastric pain, so right upper quadrant pain, blurred vision, headaches, thrombocytopenia, and pulmonary edema. The best treatment and resolution is delivery, so management is highly individualized based on symptoms and gestation. Regarding management, patients are usually hospitalized with seizure precautions, prenatal aspirin, betamethasone for those prior to 34 weeks gestation, so that steroid that helps with lung maturity of the newborn if born preterm, antihypertensive medications, as well as magnesium sulfate prophylaxis to prevent seizures. Just a little extra info that you might see coming up. Low platelets, a high BUN, high creatinine levels, maybe auscultating some crackles in the lungs, positive epigastric pain, headaches, blurry vision. Those are all associated with assessments of severe preeclampsia. Also note, severe feature is when magnesium should be started to prevent those seizures, so eclampsia. It also protects the newborn neurologically. Eclampsia follows preeclampsia. Eclampsia is identified with the onset of seizure activity. Management is delivery of the newborn once the mom is stable, and to continue magnesium sulfate to prevent further seizures for 24 hours following the last seizure. And you also want to closely monitor the fetal heart rate. Magnesium sulfate. Please note that this is going to be mentioned again later in my lecture, and you should know the two different uses for it for pregnancy complications. So it blocks neuromuscular transmission and causes vasodilation. It's administered intravenously, first with a loading dose, then with a continuous infusion. Patients who receive magnesium sulfate almost feel like they have the flu. They're very crummy feeling and they look very flushed, especially after that loading dose. As the nurse, you need to really closely monitor for deep tendon reflexes, a respiratory rate, including auscultating the lungs, as well as monitoring urine output. A decrease in these are very concerning because this could be due to magnesium toxicity. Therefore, you need to monitor these levels closely per unit policy, of course. Calcium gluconate is used in cases of magnesium toxicity, so it's important to keep it readily available. This is a chart of deep tendon reflexes. Note that you can assess different muscles besides the patellar. This is important to know because you could have a patient that's getting DTRs and has an epidural and they don't really have much movement in their legs, so it's a lot harder to check for that reflex on the patellar muscle. Also, please note clonus is a separate assessment from the deep tendon reflexes. I'm not sure why it's listed right here. But just know if you want to review that on your own, feel free, but I'm not testing you on that. That is a way to check the neurological system of the patient. HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelet count. It occurs up to 20% of patients diagnosed with preeclampsia with severe features. The patient has an increased risk for cerebral hemorrhage, rupture of the liver, goes into DIC, could also have a placental abruption as well as renal failure. Treatment varies based on severity, gestational age, and the condition of the mother and the fetus. So rapid-acting antihypertensive medications, magnesium sulfate, Steroids for fetal lung development as well as delivery are treatment options. Amniotic fluid imbalances. Polyhydramnios is a condition where there is too much amniotic fluid surrounding the fetus between 32 and 36 weeks gestation. It's associated with maternal diabetes or fetal abnormalities. Assessment includes complaints of discomfort with stretching or shortness of breath of the mother. Abdominal girth or fundal height is more than expected for the gestational age, and uterine contractions due to the stretching of the uterus. Management includes amniocentesis to remove extra fluid, as well as administration of a prostaglandin synthesis inhibitor, which decreases fetal urinary output. Oligohydramnios is a condition where there is too little amniotic fluid surrounding the fetus between 32 and 36 weeks gestation. It's associated with any condition that prevents the fetus from making adequate urine. An assessment is rule out of rupture of membranes, abdominal girth or fundal height that is less than expected for gestational age. Management includes an amnio infusion, so infusing fluids into the amniotic sac, as well as early delivery. Some risk factors that are associated with these imbalances, so for polyhydramnios, there's a risk of, the baby floating around a lot and could wrap itself up in the cord a little. And then oligohydramnios, less fluid is less cushion, so cord compression is very evident here. And hence that's why an amnio infusion could help, especially while somebody's in labor, helps add extra fluid to cushion that kiddo. Cervical insufficiency, also known as premature dilate. The cervix begins to dilate despite no uterine contraction. This typically occurs at 20 to 24 weeks gestation, which can cause premature delivery of the fetus, often before the age of viability, unless dilation can be stopped. Causes may be a lesser amount of collagen or elastin, hormonal factors, as well as pressure from the uterus. Cervical length is also associated with cervical insufficiency, so if diagnosed early on bed rest is recommended. Progesterone supplements may also be prescribed, or placement of a cerclage. So if you look over here, this is a cerclage. It just kind of helps keep that cervix closed. Preterm labor is defined by the occurrence of regular uterine contractions accompanied by cervical effacement and dilation before the end of the 37th week of pregnancy. 37 to 38 weeks, keep in mind, is late preterm status. Medications are used to slow the progression of labor as well as to help with neonatal outcomes. It's important to educate expectant mothers on the signs and symptoms of labor early on in pregnancy. Signs and symptoms of preterm labor include uterine contractions, cramping or low back pain, pelvic pressure, an increase in vaginal discharge, leaking fluids, so possible rupture of membranes, a positive fetal fibronectin, so that test that tells you the probability of the patient delivering within the next so many weeks, as well as a short cervical length. Risk factors for preterm labor includes multiple gestation, gestational hypertension, less than 18 months between pregnancies, smoking, use of substances, stress, as well as STIs. You need to know these medications, especially what you should be monitoring for. So for instance, magnesium sulfate, you need to know that this relaxes uterine muscles to help prevent that preterm labor. Preterm patients are started on magnesium sulfate not because there's a risk for a seizure like in a preeclamptic patient, but because it relaxes the uterus to help prevent the preterm labor. You want to monitor for toxicity as we discussed earlier, and you want to continuously monitor the baby. Calcium channel blockers such as nifedipine, this inhibits uterine activity. Also, Watch for the risk of hypotension. This is something that is given for patients that have high blood pressure. So if you have somebody that does not have high blood pressure and they're receiving this, they could become hypotensive. Indocin, I'm not even going to try to say this word. This inhibits prostaglandins that stimulate contractions. And just know that this can cause GI upset. And then corticosteroids, so that betamethasone/celestone. This is used to mature fetal lungs. It's 2 doses given 24 hours apart intramuscularly. It's a very thick solution, so we try to do this in the buttocks for the injection. It's recommended for expecting mothers at risk for preterm labor between 24 and 36 weeks gestation. Checkpoint. Let's say a 33-week patient walks onto a labor unit, 7 centimeters dilated. What should the nurse anticipate? What should the nurse prep for? Delivery. This is kind of the sign of no return, so you want to prepare for a delivery and have all hands on deck.